Hi, my name is Adam Gassas. First of all, I would like to say thank you for the organizing committee to invite me to give this talk. It is nice to see a lot of names of people that I work with, particularly in Sick Kids in Toronto. Anyway, thank you very much. I have a few pictures here on the first slide. I trained at Barts and Royal London, and then I did my fellowship in Sick Kids in Toronto in the middle, and stayed in Toronto for 15 years, returned back to Bristol as a director of BMT program, and now I'm back in St. Mary's here. I was debating whether to put the Alexander Fleming wing in St. Mary's or a picture of the future King of England, and I thought perhaps the future King of England, having the first child in St. Mary's, is probably better. I think the talk really is for 15 minutes. I'm trying to stick to the time. It's an introduction, and I'm going to focus mainly on pediatric ALL because it is more relevant to MABs and CAR T cell, and just a concept of the immune system. And also we talk about MABs and CAR T cell and what we've learned so far and any future directions. So the first slide is really is to share a study that we've done a while back and published about 15 years ago about the importance of the immune system in controlling pediatric leukemias, particularly ALL, because a lot of people at that time did not believe there's GVL in ALL. And this was one of the first studies that we did in Toronto, and looking at the effect of graft versus host disease by choosing an unrelated donor versus a sibling donor. And as you can see, the relapse rate in the matched sibling donor was up to 55%. In the unrelated is 22% with a significant p-value. So this is the time that unrelated transplant 15 years ago started to have better outcome because of better GVL for ALL. And this is also because supportive care and diagnostic and control of GVHD has improved significantly. But this is the concept that there is immune phenomenon in controlling relapse in ALL. And this is a larger study that we have done, also looking at patients with ALL who has GVHD. And as you can see, if you have severe GVHD, you hardly ever relapse. And this is, up to 50% of relapse if you don't have GVHD. Again, the immune phenomena of the immune system controlling ALL via GVL. Now, this is our study from children with acute leukemias going for a second transplant. So these are really, really high-risk patients. And as you can see, if you have GVHD, you have a significantly good outcome. But if you don't have GVHD, outcome is abysmal, because these are patients who are heavily pretreated, and also these patients have advanced disease. And what they need is GVL and the immune system of the donor to control the leukemia. Again, this is a children oncology group study that we were part of, with the North American Consortium, published by Mike Pulsifer about 7 years ago in Blood. And this was a randomized study of adding sirolimus to the GVHD prophylaxis. But that's not the point. The point is children with ALL who have no GVHD, again, almost 50% relapse rate, versus those who have significant GVHD have much less relapse. And you can see on the right-hand side graph, the Kaplan-Meier is significantly better for those who has GVHD. So at the end of the day, you really have the immune attack from the donor immune system controlling ALL. But at the end of the day, you want to balance the toxicity of GVHD versus the relapse and graft versus leukemia effect. And, this is another lecture, but I'm just going to give you a concept of it. We have looked at that in 136 child with ALL, and again, that's published almost 13 years ago, and we looked at those children who received transplant regardless of the donor, codes, unrelated, siblings, when the absolute lymphocyte count at day 30 is more than 0.3, the Kaplan-Meier on the right side is almost 60% survival. And this is mainly because of reduction in relapse. And those who have absolute lymphocyte count less than 0.3 at day 30, they continue to relapse and their outcome is abysmal. And this is really, really important because engraftment of the donor lymphocyte and the donor immune system makes a lot of difference in acute lymphoblastic leukemia control. And when you look at the Cox proportional hazard multivariant analysis, it's only the lymphocyte count that was highly statistically significant, not the age, not the remission status, not the conditioning, not the donor. So really, again, the immune system. And this is really important as well, because at that time, this is the lymphocyte recovery early post-transplant, and most of the lymphocyte that recovers early post-transplant are NK cells. And that has led to significant GVL, but without increase in GVHD. And I'm sure you are aware of many centers in the world who have adopted this, and they have done transplant with NK add back at certain time points to maximize GVL. But that's all just to give you an idea of the real effect and the immune attack of the donor immune system in controlling ALL. In the past, we have used a modified BFM protocol, which is the UKR3 protocol in relapsed ALL. And as you see, there was a randomization between two anthracyclines, and we know, and that's published a while back, that mitoxantrone was superior. But then you go down here, and the stratification really is based on MRD at day 35. Very similar scenario to the BFM protocol. And if you have MRD more than 10 to the power of 4, you are destined to receive transplant. You go for consolidation, intensification, and stem cell transplant. If your MRD is still high after about 12 weeks or 13 weeks of treatment on the UKR3, then you go for FLAD and then stem cell transplant. So this is the UKR3, which used to be our standard protocol. The issue with that is that there was 8% non-relapse mortality during induction. It's a very, very intense protocol, but also a lot of toxic death. So at the end of the day, the relapse protocol led to about 10% death, and also when you go for transplant, you have the toxicity of transplant, GVHD, and TBI, and all these things. So that really led us to talk to the other half of our talk, is that can we do better? Can we do a targeted immunotherapy to limit or have less toxicity? And looking at that, talking about MABs, you're all aware of the blinatumomab, the CD19, which is a bispecific T-cell engager, BiTE, and the twin molecule of the inotuzumab, which is the CD22 T-cell engager. And this is the original study by Arend von Stackelberg and many other investigators, published in JCO about 5 years ago, looking at blinatumomab as a single agent, how it is effective in inducing remission in very high risk relapse and refractory ALL. And as you can see, about 50% induction of remission as a single agent. So very, very effective. So currently in UK, our UK relapse protocol has changed. It's a gentle induction with 3-drug induction, followed by 2 cycles of blina, and then stem cell. So that hopefully to eliminate the toxicity of the R3 and having children ready for transplant in a better shape. If they relapse post-transplant, you can have CARTI CD19, which is it's a commission study in UK. And if you have a CD19 escape relapse after CD19 CAR-T, you could have a combined CD19 or CD22, which is a clinical trial, which is Amelia. I'm going to show you some data. This is the CAR-T cartoon, which you all are aware of. So you have the lentivirus vector, and you have the chimeric antigen cloned to the T cell and goes to the blast cell that has expression of CD19 and lead to cell death. Very, very impressive results. And this is combination of few study, including Modi et al. In 2014, which have it in the next slide, which is from the Steve group in Philadelphia. Very, very significant results. About 50% of patients are long-term survivors, and these are patients mostly relapsed post-transplant, and they're salvaged by CAR-T. So very, very impressive. Now, yes, there is toxicity, and there is CRS, cytokine release syndrome, neurotoxicity or B cell depletion, needing a long halt of IVIG. I think we are much better off now controlling this toxicity as we know more about CAR-T compared to when this started about 10 years ago. Now, the main difficulty of these patients is the tumor escape, and you have a CD19 negative relapse. And the way to control that is really to have a double whammy, which is a CD19 CAR and a CD22 CAR in one infusion, so to have no tumor escape. And this is the whole concept of the Amelia study that my colleague Persis Amrolia from Great Ormond Street is running. And by the way, some of these slides are from Persis that he shared with me. So the Amelia study is really good results. And, you know, as you can see, at a dose of 3 million per kilo, you have all MRD negative patients. And the persistence is quite good. And that will improve outcome, and will induce remission of these patients until you get them to transplant. So really, most of these patients could not make it to transplant because they did not have remission. Now, looking at efficacy of CAR versus stem cell transplant, this is a very, very difficult scenario. The graph on the left is a Kaplan-Meier that I have already shared with you, that has the outcome of the R3 protocol and the stem cell transplant. And as you can see, the green line is intermediate. It's about 50%. Again, the CAR-T is about 50%. Having said that, it's difficult to compare. It's very different patient population. The CAR-T patients are more advanced disease, and many of them are relapsed post-transplant. So you could say the CAR-T perhaps is more effective. I don't know. Now, toxicity perhaps is very different, and this is the main reason I think we should aim for immunotherapy compared to transplant. I think the CRS was a big problem, but now is more manageable with anti-IL-6 tocilizumab, and we monitor it very closely, and we control it closely as well. Neurotoxicity, cytopenia, B-cell aplasia, we deal with it really well. Having said that, the old protocol with the R3 and the stem cell transplant complication perhaps is more of a problem. TRM from induction of R3 is 8%. Acute toxicity of transplant, you're all aware of mucositis, infections, pneumonitis, acute GVHD, transplant microangiopathy. You could have 10 to 20% TRM. Now, late effect of transplant, chronic GVHD, puberty, infertility, malignancy, and also the issue with TBI. We hoped that we can get away without TBI, but as you know, the Forum study has concluded there's about 15% better survival with TBI. So we are stuck with it, with all the complications and side effects of TBI with pediatric ALL. So if you can, steer away from TBI, that's better. So future direction, CAR-T or stem cell or both. I don't know. I think that transplant remains the standard choice for standard risk relapse, particularly if you get a patient into remission and you have a donor. Now, CAR-T perhaps is more efficient in patients who cannot enter remission in a standard way, and you can offer them CAR-T. The beauty about this CAR-T is that if CAR-T does not persist, you can always salvage them with a transplant. But also, it goes the other way. If somebody goes for transplant and relapse post-transplant, you can salvage them with CAR-T. So it goes either way. I think CAR-T will likely to improve and evolve over time, and particularly so with having the two, the CD19 and CD22. So you could have, double killing for the blast, and in future you might have a small molecule that improve persistence of the CAR-T. And also, you really don't need radiation in CAR-T, so really less side effects. Now, this is my last slide, and this is a slide from my colleague Percy Zamrolia. Looking at ourselves now, we are like the Incredible Hulk. We just walk and destroy everything, killing immune system, and do BMT and having a lot of complications, while hopefully with the targeted immunotherapy, and say 3 years from now, we will be targeting only the leukemia cells and less side effects. And with that, I will close and be ready for have any questions. Thank you very much.